assisted cough to that as well. And if these techniques at home do not result in rapid improvement, then medical attention is necessary, such as a chest radiograph and potentially antibiotics and potentially hospital admission. So, unfortunately, as lung function declines, I like to say that sleep is the stress test for neuromuscular diseases. And this is when the gas exchange abnormalities usually occur first, especially during REM sleep, because we're not really supposed to be acting out our dreams, right, during the nighttime, because that could be dangerous, especially if you lived on a cliff's edge. So adaptively, we don't act out our dreams. So all of our postural muscles are paralyzed during REM sleep. That means that those muscles that you might use to assist breathing during the daytime, like your sternomastoid muscles, other accessory muscles, they're all paralyzed during REM sleep. So the diaphragm is left alone, which could be very weakened or mechanically disadvantaged. So REM sleep in particular is associated with low levels of oxygen and often high levels of carbon dioxide. There's also lesser central drive to breathe in response to low oxygen or high carbon dioxide levels. And upper airways resistance also increases during REM sleep. So obstructive sleep apnea can also be more common. So all of these things in particular lead to sleep problems during REM sleep. And a number of symptoms may be seen as a result of this when this develops. Fatigue, unrestful sleep, waking with morning headaches can be a sign of obstructive apnea and of high levels of CO2. And while you wouldn't in the normal population use overnight oximetry to diagnose or exclude obstructive sleep apnea, in patients with neuromuscular disorders whose lung volumes are small, overnight oximetry is very sensitive to finding abnormalities. So it's a perfectly reasonable screening tool without having to go to a sleep laboratory. If necessary, we will try to get folks into the sleep lab if we're having problems subsequently, having started treatment empirically. But generally, I don't send patients to the sleep lab. So the most common solution, of course, is going to be positive pressure mask ventilation. This is an overnight sleep study in a gentleman with Charcot-Marie tooth disorder. And you can see that during REM sleep, which is this thick bar here, there is hypoventilation and very low oxygen levels. So these saturations are dropping into the 70% range over and over again, associated with both of these REM periods. And he's on his side, which would actually be even a better condition than lying on the back experiencing REM sleep. And this is what happens. So during the rapid eye movements, which you can see here, the tidal volumes, the in and out breathing, is much more shallow than it is here after the arousal. And you can see that during rapid eye movements, the oxygen saturation plummets. There's an arousal here, and the sats drop down here really to very low levels. The tidal volume picks up again, the saturations come up, and then he goes back into rapid eye movements here, and the saturations are starting to go back down again. So this can happen over and over again. So what you can see then are periods of oxygen desaturation, particularly during REM sleep, although not necessarily confined to REM. That just tends to be the earliest stage. And because the lung volumes are small, the ventilation is diminished, then carbon dioxide levels also rise. So non-invasive ventilation should be initiated under these circumstances. And over time, one of the things that we utilize, anyone who's come to see me, is we utilize the download information from the bi-level devices. So everybody has to go to the trouble of bringing their bi-level devices in with them every time they come. And here's an individual who's clearly using the bi-level every night, but they're also using it for little periods during the daytime. And there's probably about 14 to 16 hours of use here of bi-level ventilation. So we can also monitor variables like the airway pressure. So here's a prescribed pressure of 20 on 5. This is the prescribed backup respiratory rate, and I'll briefly just make the point that I believe that all patients with neuromuscular diseases should have a backup rate, and that we should really try to provide what's called controlled ventilation. In other words, if possible and if comfortable for the individual, every breath should be delivered by the ventilator at night. And this is actually a pretty good example of that. So you can see that the respiratory rate is very stable, pretty much at the backup rate of the ventilator. And this is the fraction of breaths that are requested by the patient, or patient-triggered breaths. And they're very small. Some are around 15 or 20%, some of which is awake, so there are more triggered breaths during wakefulness. So here's a young man who came to see us from Newmarket, who had had his bilevel pressures set in the sleep laboratory over a couple of visits. And there's adequate ventilation. Well, I beg your pardon, actually, the CO2 at that time was in the 70s, but at least at one point the ventilation may have been adequate. But what you can see is the proportion of patient-triggered breaths. In other words, the individual is requesting breaths during sleep from the ventilator about 85% of the time. And when we empirically increase the pressures, which you can see here, we're providing more ventilation, and the proportion of patient-triggered breaths then drops substantially. So that now the ventilator is doing more work for the individual, and they're getting better ventilation, so their brainstem is not triggering the ventilator as often. So their muscles are resting more as a result of the ventilator doing the breathing for them. And this is a single night where one can even speculate, and I say speculate because we can't prove it, but here's the patient-triggered breaths, and you can see the individual falling to sleep here. And this much lower level of triggered breaths is actually during sleep, and there could be a bit of an awakening here. But the backup rate is very steady, and the percentage of patient-triggered breaths is very low, and I think that's the goal. And the vast majority of the young people with Duchenne I care for are close to zero overnight if we get the settings right. Now, if nighttime ventilation alone proves to be insufficient, and in the 4th stage of respiratory impairment, where ventilation may be necessary much of the day as well, as indicated by those hours of use, then there's a choice to be made. And I think in many places, once ventilation is used more than nighttime or for some arbitrary number of hours, a tracheostomy is often recommended. And I would like to go on record as suggesting that insofar as there is sufficient bulbar function, a mouthpiece for daytime ventilation using a chair-mounted volume ventilator should be tried prior to tracheostomy. And this is just a setup using some ABS plastic and a holder. So this goes around the neck, and a holder for an angled mouthpiece. This young man actually sent me postcards from Paris a few years ago, where he went on holidays with his family. So he's using a mouthpiece here. He's got a little MacGyver thing going on here to keep the mouthpiece upright. And there's a study done recently, 2006, by a very good group from Belgium. They've come out with a number of really good papers on Duchenne recently. And what this shows are individuals who need no ventilation yet, whose CO2 is perfectly normal overnight. And this shows individuals whose CO2 levels begin to increase during the nighttime, in whom non-invasive ventilation is then provided overnight to correct that. Those patients who are now on non-invasive ventilation, who begin to develop higher CO2 levels towards the end of the day and complain of breathlessness during the day are getting more fatigued, and it's in that group that they provided mouthpiece ventilation to during